So shall we move to the discussion now, Michael? We have three discussants who may contribute.
Yes, I think we should, George, and perhaps Aphrodite would let us have a little bit more time, so then have colleagues making points or asking questions. Let me briefly introduce the three discussants. Professor Davlouros, who is the head of cardiology in Patras in Peloponnese, spent some time with us some 20 years ago at Brompton. Kostas Vasileiadis, who is one of the most senior congenital heart docs in Greece, who also spent some time in the United Kingdom, in Southampton and at the Brompton from Thessaloniki, and Dr. Vlachos, who is also a pediatric cardiologist from Ioannina, so western mainland Greece. So maybe if there are any comments from the discussions, and then we open to the floor. I have a couple of points to make, but if we go through the discussions first, any comments or questions to the panel?
May I?
Of course.
May I offer some?
Dr. Vlachos, go ahead, please. Yeah.
I would like to thank all the presenters for their thorough and scientifically vast presentations. And I would like to raise a few points along the sidewalk here. Many times we prefer to have a planned pregnancy when we have a congenital heart disease, but often we come across to a pregnancy that presents with no preconceptional assessment. So I would like to raise the awareness of the cardiologist in care for the patient to emphasize that the planned pregnancy is better for the outcome of both the mother and the fetus. The second point I would like to make is the use of submaximal exercise, especially in such cases where we can assess the exercise capacity, we can search for induced arrhythmia and monitor the response of heart rate and blood pressure. I find it better after 12 weeks of gestation to be contributory to the outcome. Another thing is that we often use CMR to assess the mother, and there are some growing evidence in the literature about toxicity of gadolinium. So that's another point to have in mind, that when we use CMR with gadolinium, to avoid, especially in the first 12 weeks of gestation, or discuss with the parents. From the eye of the peripheral hospital that I am, I would like to have a multidisciplinary team here, because it helps a lot to have the cardiologist that knows and the fetal specialist. And don't forget about the fetal assessment as well, because there is an increased risk to the embryo to have congenital heart disease of any type. And my final comment is the emphasis on the continuous adaptation of guidelines. Since the rarity of these diseases, most of the recommendations are experts' opinion. And I have to underscore that the experts do reserve the right to change their opinion from time to time. Thank you very much.
All valuable points, Dr. Vlachos. I'm not sure what constitutes an expert, but there you are. Does anybody from the speaker would like to address the second point about the value of exercise testing in sort of assessing patients leading to pregnancy? Kathy, would you like to say a word about it, please?
Yes, happily. Yeah, I completely in agreement with you. I think, particularly as I pointed out in my talk, I think it's extremely important in outflow tract stenosis, so in aortic stenosis, in preconception assessment. I've got an interesting case that I often use of a young woman with subaortic stenosis with a very significant gradient, who fortunately had happened to have an exercise test as part of her transition from paediatric care. She was only 16. The exercise test showed she had excellent hemodynamics. It was very fortunate we'd had that when she then presented with an accidental pregnancy 8 weeks later. So I think it's extremely useful. I think it's extremely useful for two reasons. One is hemodynamics. The other is exercise capacity, when we all know that we can sometimes all be a bit not quite clear about how much exercise we're really doing. And you know, we all do that too. It's, yes, I walk 5 miles, I walk 10 miles. And it's very, very useful to get an objective assessment of that. So completely in agreement with that. Can I just pick up briefly on your first point, Dr. Vlachos, which I'm really in agreement with as well. In the United Kingdom, we find that actually it's the women with congenital heart disease who have much more pre-pregnancy counselling, because they're all in congenital heart disease, or most of them in clinics, where it is completely normal to discuss with any woman or girl of childbearing potential contraception and pregnancy plans. It's just something you discuss every time in best practice. Whereas we find that the people who present without any form of pre-pregnancy counselling is much more the women with acquired heart disease. And we are working hard to get that message out to our acquired heart disease cardiology colleagues to do the same thing, to just discuss in every single clinic, how you're thinking about pregnancy, just make it a normal question. So I really agree with you about that.
And just to back what Kathy is saying, also women with rheumatic heart disease who are immigrants, so they're undiagnosed disease that they can present during pregnancy, as I think was alluded by you, Kathy, in your presentation. May I make a suggestion that we extend the term pre-pregnancy counseling into what is, I think, an obligation, and we have failed as a profession to do so, to share the information about the life trajectory for patients with a lifelong disease, which is congenital heart disease, and family planning, and the risks involved and the opportunities must be part of this communication and education of the families, first of all, the couples having a fetus diagnosed with congenital heart disease, and certainly with a teenager, not only about contraception, but about for what the pregnancy may mean to the individual patient. And also, importantly, what lifestyle choices may affect outcome of pregnancy and of a lifespan and quality of life of the patient. Just to be more specific, a simple example, you've got a patient who has single ventricle physiology, has a Fontan operation. That patient, the best investment after the Fontan completion is to be slim and athletic, is the new aspirational mantra, but I think it's highly related to patients, highly related to all of us. I'm sorry, I'm very opinionated on this, but I believe this to be true. So if you have a female patient with a Fontan operation at the age of 4 that is looking good, the next best investment and thing that the patient and the family can do to be slim and athletic. And to know that pregnancy, the best time to have children is not too late. And to know in the right environment, which everybody spoke about it, in the multidisciplinary environment and support, that the risk of pregnancy is not prohibited. It is actually low. So if you go to the best end of the Fontan, and Eric, you showed us a patient who had 3 children. Obviously, this is not the average patient, but nevertheless, the best, so the risk to a Fontan patient is very, very low, but the patients and their families need to know about this, need to know about the lifespan. So if somebody is at the good end of the spectrum of Fontan and has the first child at the age of 25, probably they've got another 20 years in good health to be able to support that child. And of course, the risk of recurrence of congenital heart disease, which in general is small, as Dr. Vlachos alluded to. So I think this is something that I have failed as a professional to communicate with patients in good time. So I think the preparing the patients, it's a process that starts much earlier than before a woman with heart disease contemplating starting a family. And then you've got a better outcome. It may sound an extreme position, but I believe it to be true. I'll stop here. Any comments or questions from the floor? I'm not sure, we don't see who is in the hall. I presume there's a large audience, Aphrodite.
So thank you, Michael. Thank you all to all the speakers, the chairman, the commentators. I'm told that we've had more than 1,000 attendees this morning. That's down to all of you. Wonderful sessions, wonderful comments. Thank you for the lectures. It has been very nice to see colleagues and friends from afar, from other places in Greece, and also from abroad. Unfortunately, due to the pandemic, we cannot be together. It would be very, very nice, but at least we saw you even virtually. That was wonderful for us here. All of us at the auditorium would like to wish Michael Gatzoulis happy birthday.
Happy birthday.
Thank you.
Happy birthday, Michael.
Michael, thank you for sharing your birthday with us today. Michael Gatzoulis is world renowned. We know that. And this birthday led to a lot of advances in congenital heart disease, a lot of knowledge obtained due to Michael, a lot of trained people due to Michael. Thank you very much indeed for everything. Now, the day today was mostly focused on the mother and child and the fetus with congenital heart disease. Tomorrow, we are going to focus more on interventions and cardiac surgery. And we do hope that we will be all together tomorrow for the live sessions. And with your contribution, it will also be a successful day. Thank you so very much, all of you.
Thank you.
Thank you. Thank you so much.
Thank you.